session on the webinar series. We've had the first two. The first one was on the spiritual care, integrating spiritual care in the case of Switzerland. And the second one, last week, we looked at the situation in Austria, and we were very pleased to go to the Netherlands this afternoon. So with us, we have Professor Erik, and we're going to be looking at the spiritual care also in Netherlands. So without much ado, over to you, Professor Erik. We are really pleased to have you. Thank you.
Thanks. Share. Yes. If there are any questions, please do so in between. That's all fine. We are with a small group, so just catch up with me meanwhile. It will take around, I think, 45 minutes, maybe shorter, but we'll see. And then, of course, we can also discuss if there are any things left, questions, remarks. I'm a professor of chaplaincy studies at the Protestant Theological University in Utrecht in the Netherlands. And besides that, I'm also an ethicist in a review committee, Euthanasia, that's part of the Netherlands Department of Health. And until this month, I'm also editor-in-chief of Dutch Journal of Chaplaincy Studies. And before that, and some of that will come back in my presentation, I chaired the revision of a national multidisciplinary guideline, grief and palliative care, in which spiritual care was also a central topic, not the only one, but one of them. And I worked as chaplain in palliative care and in psychiatry. My aim is to provide some insights on spiritual care and palliative care in the Netherlands and to reflect on some differences and similarities between European countries. What I hope to do is to provide some backgrounds of spiritual care and palliative care in the Netherlands, and then dive into it. The division we commonly make in our country between specialists in spiritual care and generalists in spiritual care. Then I'll come to the European perspective based on a systematic review study, and discuss the role of interfaith spiritual care. So how do you provide care, spiritual care, to people with other religious or spiritual backgrounds than your own? And I draw some conclusions. I think important, I wasn't there when the presentation from the one from Switzerland was presenting, but so maybe there is some overlap. The countries do have some overlaps as well, but also differences. What you see actually is that there are two theses often used in sociology of religion. The secularization thesis has been used for a long time and has been confirmed as well. And shortly, that means that everything that relates to institutionalized religion, so Islam, Christianity, and so forth, has decreased over time. And that's the definition offered by Charles Taylor in Secular Age, that the religion or the non-religious worldview is optional. So that means that we are aware or increasingly aware that how we view the world and what is important in that, at least in our sort of countries, that you could also see it otherwise. Your faith, your beliefs, whether they are religious or not, that doesn't matter. But besides that, there was also the transformation thesis, roughly for about the last 20, 30 years. And that means the shift away from institutionalized religion towards individual spirituality / meaning. Well, that's also what's been described in the spiritual revolution, why religion is giving way to spirituality. So that means that not the Islam or Christianity or Jewish communities prescribe what their believers have to believe, but that people give meaning to their lives in their own ways, and some draw from religious sources, but they do so in their own ways. That's actually what this transformation thesis says, and which has been confirmed regularly. And for those working in healthcare, probably recognize it as well. At least in my country, that's the case. So that's the background of spiritual care, but then palliative care. We were actually the first country in the world where euthanasia was legalized in 2001. But it's also the reverse chronology. So we first had debates on euthanasia in the 90s, and then palliative care came into focus. While most countries first settled palliative care and then started discussing about euthanasia. We just call it euthanasia, and um, it's not a negative term in our country. In some countries, of course, it's associated with the Second World War. So, well, then you can also read uh, physician-assisted suicide or um, Sterbehilfe in German. Palliative care from the early 2000s has been developed quite quickly. And it also included the development of guidelines. I will come back to that. And spiritual care was in the plans for palliative care, described in the plans for 2008 to 2010. Then about spiritual care and palliative care. Um, In palliative care, it is seen as a team approach. This may differ in other context, healthcare context, but in palliative care, it's ideally a team approach, which means that both generalists and specialists in spiritual care provide spiritual care. So generalists like nurses, like volunteers, like doctors, they are assumed to provide spiritual care as well, at least at a basic level, which means, for example, paying attention to spirituality, to what matters most to the people, to the patients you work with, and their family members. The reimbursement, that's quite different in several European countries. In our country, it's mostly funded um, like the rest of care is funded. So I won't dive into details here because it's a complex system. But in the end, it means that it's provided by the government to a great degree or covered by healthcare insurances, um, which is different in several other countries where the church pays for the provision of spiritual care. Um, so again, the focus is on spirituality slash meaning, which include but is not limited to religion. So people with an atheist or an agnostic or humanistic or a mixed background, um, they can also receive spiritual care. And I would say that 8 out of 10 patients I provided spiritual care to were non-religious or were once baptized, but that played no role anymore. Um, but still, they wanted to talk to me about things they hoped for the next day, things what they worried about at night, and so forth. Um, but if you say generalists also provide spiritual care, then that presumes, of course, that these generalists know what spiritual care is, which is not always the case, and there's still work to do there. But it also means the setting up of education and training programs. Um, and specialists in spiritual care, like chaplains, they teach others quite a bit as well. And I did that too. So I gave trainings over the years. I still do to GPs, to lung physicians, to nurse specialists, and many others, volunteers. Then about the quality of the quality of spiritual care and palliative care. One way of steering on quality is by developing and using guidelines in which evidence is collected uh, for for or against certain actions. The first guidelines were developed in 2010, but they were not yet evidence-based. Um, and in 2018, we had launched the existential and spiritual aspects of palliative care, the guideline. Um, Shortly said, it's the guideline on spiritual care and palliative care. And in 2022, the grief and palliative care guideline was launched, which I chaired on account of the Dutch Association of Chaplains. That's two important ways of trying to support people to provide spiritual care in a good way when it comes to grief or spiritual care in general. And also, for example, to offer suggestions for what you could do, or maybe shouldn't do, or what you should take into account. So often these guidelines have a same structure. They have a question, and that question is answered stepwise in the separate chapter. Then the specialist in spiritual care. Of course, you have the faith-specific spiritual caregivers, mostly connected to religious communities. So imams, pandits, and so forth, rabbis. And one example is the church I am a member of, the Protestant church in the Netherlands. Approximately 9% of the Dutch population is a member of this church, which makes it the largest Protestant church in the Netherlands. Nowadays, we have, I think, roughly, of course, it always is a debate what you count and don't count and how you count. But roughly, I would say that 45% of the Dutch population call themselves a believer. So that means that a majority in these days is a non-believer. Although, again, it is a question whether it's that dualistically framing, whether that's okay or whether that does justice to reality. So, for example, this church has a bit more than 1,800 local communities of faith and 1,352 ministers, which we teach as well. So my institution teaches both people who become a minister in church and people who become a chaplain, but feel connected to or draw from Protestant faith, among other spiritual sources. Then the National Association for Chaplains. I think these numbers are maybe a bit, I would say that probably they are this year already quite a bit different. So probably the non-ordained ones, the no ordination chaplains are the largest group now, or almost the largest group, or soon will be. But these numbers are, I think, from 2024 or 3. Then you see that the Protestant slash evangelicals the largest denomination of chaplains, but it is decreasing. The Roman Catholic 300s also decreasing. Well done, no ordination. It's increasing, and humanistic, not as fast as the non-ordained ones, but it's also increasing. And I think this number of 120, that may be a bit low, but that depends on how you count and also how these the association of chaplains. Not everyone is a member of the National Association, so, but still, it gives some trends. Another trend is the increase of professionalization, which means a decrease in the importance of ordination. That is mostly the case in healthcare settings, as far as I can oversee, but it is less the case in prison or military settings, where ordination still plays quite a major role. But also there you see debates originating about whether it's still relevant to be ordained or not ordained. It's different. So the increase in professionalization also means that the difference from the classical minister, priest, imam, etc., is emphasized, maybe increasingly emphasized, though I hold the view that they are not so different that it's totally something else. Because when you work for example, as a church minister in the Dutch situation, you also have to deal with quite a variety of believers, which it is very, I think it's the most diverse church of the Netherlands. And also, of course, when you lead a funeral service, you also have to deal and talk and support family members who sometimes aren't religious at all. And what also belongs to the professionalization trend, and the emphasis on professionalization is the increase of empirical research. More specifically, the legitimization. Sorry, I think I wrote it wrongly, but anyway, you understand it hopefully. According to the prompts, so the patient-reported outcome measurements. So, good spiritual care, to say it shortly, good spiritual care is good when it offers the patient something good. For example, peace, rest, being able to integrate an event into your life story, that kind of outcomes. So it isn't formulated from the point of view, at least not so much anymore, from the point of view of the giver, the spiritual care giver, but from the spiritual care receiver, which in the end I think is a good thing because it is about these people receiving spiritual care, patients with a life-threatening disease and their family members. It doesn't mean that patients can say everything they need and you just have to follow them only. Of course, there's some awareness, which is good too, that maybe not every need needs to be fulfilled. That depends on the situation. We can talk about that later. But overall, I think it's a good thing. And it also shows the emancipatory side of in which patients are a very important voice in the care they receive. Obviously, I would say. But um, the majority of the current chaplains still has an ordination, though I already said that the non-ordained ones is growing. So we did a survey 2 or 3 years ago among chaplains ordained by the Protestant Church in the Netherlands, so the one I was just referring to. And overall, they said that ordination mattered, but mostly to themselves, um, or when doing something typical that belonged to their own religious tradition, like leading a church service. But not so much, they didn't stress the importance for patients. And that's also been, I didn't quote that study here, but one of my former PhD students, Anke Liefbroer, she also investigated whether it mattered for the evaluation of the conversation from the patient point of view, whether the kind of ordination or the kind of or non-ordination of the chaplain mattered from the point of view of patients in a hospital. And overall, the evaluation was quite similar when there was a faith concordance compared to when there was faith disconcordance. So when they had different faiths. And of course, again, like I already stressed, context matters. Um, because you see in the military and prison and sometimes diaconal contexts, like chaplains working at the streets or with people addicted with addiction problems, sometimes it matters that they are also a religious figure, like an imam or like a minister. We can discuss about that, but maybe it's not relevant to you. We'll see. Well, what we also see in our country is that, of course, the generalist in spiritual care, um, there are several, it's always difficult to explain why something happens or to give one factor, but I witness some trends at least that also generalists in spiritual care, roughly speaking, we've had after so the baby boom generation was quite anti-religion for good reasons, I would say, because they had grown up um, in times where the church had a lot of power over them. And you see in the 60s and also in the 70s the democrat, democratization processes of this generation. Um, but most of them have retired now, and they were always so. When I would say I'm a spiritual caregiver or I'm a chaplain, then immediately it arose something a bit anti, which I understand. But you see, actually, with the younger generations, and that's most of them are the working populations these days, you see a new eye for, I would say, post-secular spirituality, or perhaps I should say spiritualities in plural, which means that they are, like I quoted Charles Taylor in A Secular Age, they are aware that you can also see things from a religious point of view, but that's not an overall view that tries to force them to believe that as well. No, oh, that's interesting that you see it that way, because and also the majority of the Dutch population is no longer religious, or at least not religious in the institutionalized sense. So there's a sort of new openness, which is interesting. You also see it's not massive numbers, but you see some in the latest sociological reports, um, that there are that the youngest generation, so I think it's mine 22 and younger, that they are a bit more religious than the generations higher than them, which is interesting finding, I think. We have to see what that means. And it doesn't mean that again, that I'm from the old-fashioned idea, at least in our country, that I want to have them in church or whatever. That's not my goal. But it's interesting to see it, that it is differently perceived. Um, and also that healthcare should spend time and energy and attention to what people believe, how they approach life in general, how it touches them. Of course, that overlaps with psychological care. Of course, that overlaps with physical care or with social care. But still, that there is something in there that really matters and deserves attention. Um, so that's interesting. I think what I witnessed when I started my studies in the early 2000s until now. Um, Another reason maybe, but again, I should be cautious here because it's always difficult to explain why trends happen. But I also see that healthcare is under pressure. So the biggest issue in our country and in almost each European country is the decrease of working population and the increase of the older population as people grow older, but they don't grow older more in a more healthy way. So they still have chronic diseases and stuff like that, which means that there will be a large pressure on most healthcare providers. Um, and I would say that also increases or puts under um, critique or why would I want to do this? Why would I want to provide care to people if there's so much pressure on me, if I have to work so hard? So that also maybe that also gives rise to the kind of questions that relate to spirituality or meaning. What does it mean for me to be a nurse? Why do I want to be that? Why do I want to work in healthcare at all? Um, so that's also, and what we witnessed in for example, that's a side path as we talk about palliative care here. But in psychiatry, you see it as well that you've had all kinds of turns there as well, of course, like the biological turn. But you see that part of the psychiatrists, they also missed that the conversation with the patient was once the leading thing in what they did to determine what kind of care was appropriate, what kind of pills people needed to have. But nowadays you see that there's a sort of uh, some psychiatrists miss that they can connect on that level to patients, and then they also grab spiritual care to make clear that they do something in that regard as well, which made us edit this volume about the interface between spiritual care and psychiatry. I think also what perhaps exemplifies, or perhaps it steered the tension to spirituality and to spiritual care, is the implementation of spiritual care guidelines in palliative care. And what a colleague and she's a doctor, and I did was write a paper or write a chapter in a book on spiritual care and palliative care, what it is and why it matters. And we describe what, in our view, based on she was involved in the development of spiritual care guideline I just referred to, and in the grief guideline, and I chaired the grief guideline. And we were reflecting on that, what actually makes it a good way of implementing these guidelines, also by the organizations that mostly support the development of these guidelines. Well, then that is early involvement of stakeholders in the development and until the authorization of a guideline. and after that also the implementation, of course. And stakeholders are, for example, the associations of healthcare professionals. So the organizations, the associations of GPs, of lung physicians, of oncologists, but also the organizations of the nurses and the nurse aides, the association of the chaplains, to include them already, and other stakeholders as well, of course. Well, each country that's different, but an emphasis on the multidisciplinary nature of guidelines. So each palliative care guideline in the Netherlands is always written based on evidence, if possible, but it's always written by a multidisciplinary team consisting of social workers, of nurses, and so forth, physicians, all kinds of different physicians. So the emphasis on the multidisciplinary nature also helps to make clear that spiritual care in this regard is not just you can't just say, oh, that's for the chaplain, spiritual care, or you can't just say, oh no, this person is not religious, so it doesn't need spiritual care, because then you're reasoning from the old paradigm of religion, which is no longer the case anymore in our country. Although it still happens, but it is changing. Education is an important element of good implementation of spiritual care guidelines in palliative care, which of course relates to spiritual care competencies and the development of that. I'll come back to that when I refer to a review study we did on spiritual care and palliative care in Europe. Also, the education on how to collaborate multidisciplinarily in spiritual care. So that also counts for the chaplain, of course. So currently, I supervise a PhD student who exactly focuses on this. So the collaboration, mostly focus on the chaplains, but also focusing on ministers in churches. How do they collaborate with nurses in the local area? Do they collaborate at all? And what does it mean? And how do you deal with confidentiality? Stuff like that. A last element of good implementation of spiritual care guidelines in palliative care is the investment in scientific research. Again, with special attention paid to the PROM, so the patient-reported outcome measurements. I'll just take a sip of my coffee. In 2018 and 19, colleagues and I conducted a systematic review study. So by searching all kinds of electronic databases according to a specific method, about spiritual care and palliative care in Europe. Only focusing on that's an important limitation, but only focusing on the 2015 till 17 literature. We did a big search, so we had to limit ourselves, but it gives maybe some interesting insights. Well, then you see the variety of designs, qualitative, quantitative, mixed methods. You saw that most research is conducted, at least in these years, in Western Europe, mostly in our own country, but also in the UK or Germany. In Northern Europe, 7 studies. Southern Europe were only studies conducted in Spain, 6 studies. And Eastern Europe was only 1 study conducted, which was in the Czech Republic. I think we have to discuss that because it gives food for thought, I would say, that there are so many different emphasis. Of course, that relates to wealth and economics as well, but not only. Well, what did we find? That spirituality was defined in quite different ways, which was no surprise to us, but okay, it's important to describe that. It was described as meaning or search for meaning. In terms of relationships, significant relationships, in terms of hope, etc. And EAPC, so the European Association of Palliative Care, which has every year a big congress somewhere in a European city. That task force spiritual care, nowadays it's a reference group spiritual care, defined it, and it has a lengthy definition. That definition was also used quite regularly. You can find that, but it tries to cover quite many aspects. And that's good because then many people can relate to it. On the other hand, it's always also a limitation when you have a very lengthy definition to work with. It makes it also more difficult. Spiritual care was described as attention with spirituality in terms of empowerment, in terms of presence, in terms of bringing peace. And I would say that the last one may be typically spiritual care and palliative care, while the first three, as far as I oversee the different fields, different contexts where spiritual care is provided, would also, of course, they can also say bringing peace, but peace is something that is typically often referred to in palliative care. And it implied narrative, so working with stories of people, seeing structures in stories, seeing how people divide roles when they tell about themselves and others, but also how they perform themselves, how they make a plausible story, how they try to convince you by telling about what happened to them, and so forth. Ritual, very important as well. So then we also touch a bit more on the aesthetics. So how we act, how we perform, um, sometimes in a repetitive way, and the creative work. Actually, the effectiveness of spiritual care was measured in only in two RCTs. It was described in several studies, but the RCTs are in according to the paradigm of evidence-based medicine, are the highest form of evidence. Well, a study on spiritual history taking showed that it had a positive effect on nurses and physicians' felt relationship with the patient. On the other hand, another study showed that it had no effect by the same researchers, no effect on patients' spiritual well-being, quality of life, pain, and patient-provider trust. So it's interesting to see the difference from the perspective from the patient, either from the patient or from the healthcare provider. And mindfulness with palliative care patients, and I think that there's some more evidence already for that, also outside palliative care patients, but I see that the T is lacking, patients. Um, that there is evidence for the good effects of mindfulness. It correlated positively with life satisfaction and negatively with mental distress. It had a small but significant effect on the state of mindfulness. So that means a more state than just doing mindfulness. And then the requirements to implement spiritual care and palliative care. Obviously, it was to develop spiritual care competencies. So, how are you competent? Can you become competent to provide spiritual care, but also visibility of spiritual care and palliative care? So, for example, it means that chaplains participate in regular structures. For example, a patient discussion that is held every week in many healthcare settings. So, like in hospitals, like in hospices, you have patient meetings, which important things about patients are discussed. And if chaplains participate, then you see that the awareness of spiritual care and palliative care grows as well, which is not a surprise, of course, but it shows that how important that is when you want it to be part of palliative care in general. This is a slide about because when you provide spiritual care in such a pluralistic settings, pluralistic means that it is in plural, these spiritualities and the faiths and the beliefs and also the non-religious beliefs people hold, then you have to deal with these differences, of course. And a former PhD student of mine, she started her PhD with doing a review study on interfaith spiritual care, and she distinguished normativity and capacity. So normativity is reasons for wanting to provide interfaith spiritual care or not wanting to provide interfaith spiritual care. And then you had universalist approaches. So then, for example, prayer was rather interpreted as something unifying, also prayer with people from another faith. But to others, of course, that's not done. And they held more particularist approaches, mostly faith concordant acts. So that you provide maybe conversations, you can still have them with people with other faiths, but doing rituals that typically belong to a specific faith tradition, that's also where the discussions arise. And that's also what we see when I discuss it with colleagues at other institutions. It's a common thing to discuss if you want to do that or not. But overall, many chaplains do hold universalist approaches when it comes to supporting people by talking to them, for example. Because that's also what the organizations, and that relates to the capacity, organizations want. They want you, to, of course, to provide spiritual care to everyone. I say of course, but in my situation, that is of course. So the capacity is another element of interfaith spiritual care. Are you able to provide interfaith spiritual care? So the competences to create an in-between space. So are you able to support people and find what is most important to them or how it changed their lives without trying to make them a member of your own faith? Because that is important in respecting that people have their own stance in life. Knowledge of other spiritualities, of course. So understanding a bit about the sevenfold path and so forth. To just mention one example. Contextual restraints and possibilities. So contextual restraints, you see it sometimes. So you had a book, I think around 15 or 20 years ago, on understanding Muslim chaplaincy. And it was an interesting book by Gilead Ray and others. And it showed that if there existed difficulties in the provision of Islamic spiritual care, then gender and language were often barriers. Of course, it's 15 to 20 years ago, and it was conducted in the UK. These days in our country, we see that some Muslim chaplains provide faith-specific care mostly. So they may hold particularist approaches, but there are also several that I know who provide interfaith spiritual care. So also to people with all kinds of backgrounds. Well, some conclusions, and then we can discuss if you want. Spiritual care is about, I would say, what matters. What matters to people, or more specifically, on what matters to patients with a life-threatening disease, their beloved ones, and their formal caregivers. The evidence for the spiritual care and palliative care is low, but higher than in some other contexts. And especially studies focusing on the outcomes in terms of patient-reported outcomes measurements need to be conducted. Education for generalists is necessary. So expert in spiritual care, so like chaplains, and like I did myself, should spend some amount of their time on teaching others, like nurses, physicians, volunteers, etc., social workers, to equip them so that they are able to provide spiritual care at the basic level. So in the hospice where I worked, I mostly supported patients where there was already something at stake to them, as the nurses and volunteers already did provide spiritual care at the basic level. So I got most of the situation there where there was a crisis and so forth, which made my work more heavy, but which also was very nice that spiritual care was such a team approach and embedded within care as such. There are differences in Europe. How to explain them is always difficult. Explaining differences is more difficult than just showing them. There's a lack of research in large, and I would say mostly Roman Catholic countries, such as France, Italy, and Eastern European countries. Some are more Protestant, but some are more Roman Catholic as well. It could be, but that's just something we may discuss or may not. Depends on what you want. Perhaps they reduce the spiritual to religious. So maybe the transformation thesis is mostly confirmed in more Western or Northern Western European countries. Could be. I don't know. And interfaith, the normativity question is important. So when providing spiritual care to people with other faiths or no religious faiths at all, but maybe humanistic views on life, or their worldviews. Then there are two questions always important, at least two questions. Do I want to provide interfaith spiritual care or not? And am I able to provide it given my competences and the context in which I'm working? That's it.
Thank you so much. Thank you so much for that very comprehensive presentation and quite academic too, but really giving us like that overview of the spiritual care in palliative care in the Netherlands. Please do feel free to ask questions. If you can just unmute yourself, maybe introduce yourself, which country or which organization you work with, then you can ask your question based on the presentation we just had. No question? Everything was well understood?
Is this new compared to your country where you all are from, or is it quite common? Who says it's quite new?
Please feel free to let us know how it is in your country. We saw that there was one study in the Czech Republic, and I know there are people from the Czech Republic here, and in Germany,
Of
the
course, and of
UK.
course, again, it was 2015 till 17, but maybe it says something. So it is a limited, of course, a statement.
Yeah.
But when at the European Conference for Palliative Care,
Mm-hmm.
in the reference group on spiritual care, you also see that some countries are hardly present there.
Okay.
So
I
that's
didn't say anything
interesting to
about
see.
I didn't say anything about the Nordics. Is there some, do you have an idea of what happens in the
Yeah,
Nordics?
well, in that review study, we had 7 or 9 included studies, so it is studied at least.
Mm-hmm.
Um, and it also relates if there's a sort of state church. So most of them are Lutheran, so Protestant. But it's also a state church. So my guess would be that, like we have with the non-ordained chaplains, that's quite a unique development compared to the rest of Europe.
Okay.
Um, and I think it's not so common there either, as far as I know from colleagues from there. But of
Mm-hmm.
course, it's I have a limited view too.
Okay. Then when you were talking about the team approach, I really did have the question about uh, the if a nurse, for instance, doesn't want to, take the training, they're not open to it. Are they obliged or are they morally obliged to take the training to provide spiritual care? Since you're talking about the team approach.
Um, that's a difficult question because we are, in general, it is nowadays, it is part of the competencies expected from nurses working in palliative care. So in that sense, they should provide something. It doesn't mean that they have to pray with someone.
Mm-hmm.
It means at least signaling that there is something going on with the patient when it comes to spirituality. So someone says, "My life makes no sense anymore at all," and
Mm-hmm.
that you grab that kinds of signals.
Yeah.
Uh, that's the first step.
Right.
So it doesn't mean that they have to do
Mm-hmm.
religious rituals or something like that.
Mm-hmm.
No, that's a step too far, but at least signaling it, yeah, they are expected to.
And depending on the need of the patient, they can maybe
Of
refer
course,
you to the chaplain
yes.
or to the
Yeah.
imam. Or okay.
And some patients, sometimes they did it themselves. So there was a patient who said, I don't want more people on my bed than I already have. And then the nurse provided the spiritual care. And I had a conversation with her every week for about 5 minutes. And we talked about, are you able to do it? Is it okay? Other questions. So then you function as a sort of expert at the background
Yeah, that's
while the
quite
nurse was
interesting.
providing the spiritual care.
Mm,
And the patient got distorted because she was tired and she didn't want to have more people that she didn't know, which I fully
Mm.
understand and accept, of course.
Yeah. Yeah.
Excuse me, Eric. We have a question here in the chat from Jitka,
Yes.
who is in a busy office at the moment. So she has messaged me directly. She says that she's quite new to palliative care and has found this idea very inspiring, as it's not a concept she has come across in the Czech Republic as of yet. She's wondering if you could speak more to the involvement of social workers and nurses and the training that they have received in this.
Yeah. Um, that differs per country, of course, again, although you also have some standards they have to adhere to. Um, so I'm not sure for social workers, but I am quite sure for nurses that they have to be able to recognize these issues in patients these days, or it is developing towards it. In palliative care, it's already quite, so the specialization in palliative care there, it's already quite embedded quite well. But my expectation would be that it would be within now and 10 years that it would be part of the competences each nurse needs to have. For social workers, I'm not sure. Um, Social workers, of course, they have in the Netherlands, they have a different emphasis. So some are more focusing on the psychosocial care. And then, of course, it comes into view more easily. Others are more focusing on the like organizing that someone has money to have a living, do all kind of practical stuff, organize it, support, and some do combinations as well, of course. But I could imagine that in these more practical ways that spiritual care may not be so common, but it's hard to tell. On the other hand, you could say if you work with people who have no money, that gives, of course, often leads to many crises, also in an existential way. So I would also expect that it is present there, but I'm not sure that they are taught that way. I don't know if this helps, but
Right, thank you. I see Ebenezer from
Yeah,
the UK has raised his hand there. Ebenezer, if you'd like to.
yeah, thank you very much. Like I've already introduced me. I'm just wondering, does the palliative care in the Netherlands makes use of the volunteer, or what are the roles of the volunteers in the Netherlands in the palliative care settings? Because where I am here in the United Kingdom, I work for the NHS here, and our volunteers have been one of the important, I mean, they're holding one of the important roles with us, supporting the substantive chaplains. So
yeah.
is what's the role of the chaplaincy volunteer in the palliative care in the Netherlands? Thank you.
Do you mean the chaplain as a volunteer, or do you mean the volunteers in palliative care?
Chaplaincy volunteer in the palliative care.
Um, we don't have that actually.
Mm.
It's almost always it's reimbursed, it's paid. Um, so we hardly have that people volunteer. Of course, there can be people can be members of a church or a mosque, and that they are visited by an elder or however you call them. But the volunteer chaplain is not so much a common thing in our country. No. But and the other thing, volunteers play in a very important role, but that's not the volunteer chaplains, but volunteers in general, and they also follow courses. And I think I taught around five courses, five times the same course to volunteers in palliative care over the past years, so that they are also able to, when they bring coffee and someone expresses something, that you are sensitive to what's happening there, or when you're supporting them, the nurse or the nurse aide, when uh, giving a patient a shower, then a conversation may arise sometimes. Or you see a tattoo on someone's body, which can also be a reason to start a conversation, because tattoos often say something about what is important to people. Um, so there are all kinds of important signals. But if people get more into crisis and stuff like that, then they often just signal it or tell the nurse or tell me as a chaplain. But the volunteer chaplain, no, that's not. I don't know many. No.
Like here in most of the NHS trusts in England, and especially where I work, we have volunteers that assist us in carrying out this, though not the core duties of the substances, but they are always there to support us, visiting patients, and, allocated some wards to visit and, listen, and sometimes brings, a referral, to, yes. So they
That's
are,
very good. That's great when you have that.
thank you.
In the Netherlands, we see that the volunteers and finding volunteers in palliative care is not easy, but it is easier than in chronic or long-term care.
Mm.
So palliative care is a bit more catchy, so to speak. So people want to do that but working with someone as a volunteer or people who are in nursing homes for about 2 years or 3 years, that's even harder because you have to need a certain endurance to be always there.
Mm.
So I see more struggles in volunteers, finding volunteers in these other sectors more than in palliative care, although it's not easy there either.
Mm.
And with the aging population, also, of course, hits that. Um, although in the hospice where I worked, there were quite some people who were, let's say, between 65 and 80 years old, 80. And there were quite many volunteers in that age group. So people who stopped working in a paid job and then started doing, so that's fantastic when they want to do that.
Mm. Mm. Thank you very much, Erik.
Okay. Any other question while you're thinking about your question, or maybe not? I was just wondering because I think with palliative care, it's really heavy stuff, if you can put it that way. Like navigating the meaning of life towards the end of one's life, I think it can really be tasking. So I did wonder, is there like psychological support, if it makes sense, to the persons who give spiritual care? I don't know. Is there some form of support
Yeah, it
to
depends on the setting. Depends on
Yeah.
the setting. So in hospice care, for example, it's often only nurses and sometimes a chaplain, not always, but sometimes, no, regularly a chaplain, and a physician who is working at the hospice or is a GP in the area of the hospice. But then social work, psychological care is not so much available, but I did make referrals to a psychologist. But the thing with psychology is that several treatments, of course, well, in the first place, um, you always have to wait before you can have psychological care for a couple of weeks or months. That's problematic in a hospice because people will be dead probably by then. And the expected effects of psychological care are sometimes a bit longer than in a few weeks. So that's also, but in some instances, like traumatic experiences, I did make referrals to a psychologist, and then it is also reimbursed. Um, but in hospitals, for example, it's a different situation. So there, often you have psychologists and or psychosocial workers and chaplains. So that's more available there. Um, Nursing homes, it depends. You often have psychologists as well. So yes, and then you discuss what would be the most appropriate, and with several patients, you can also discuss it with them, uh, um, which care would be most appropriate. The art, I would say sometimes they see each other as enemies, but I hope that that doesn't happen because that's always you better see each other as colleagues who try um, to have overlap, but there's also something specific you do, and there's overlap here, and something specific I do, and then discuss as a team what would be the best approach. And if possible, discuss it with the patient too, but it depends, of course, on the patient. So like in dementia care, for example, it's important to collaborate a lot to see what is best.
Okay. Thank you so much. I appreciate that. If there is no other question, I would just like us to give a clap to Professor Olsman for teaching us this afternoon, because that was quite revealing and comprehensive. So thank you so much for your time.
Thank
And
you.
next week.
Sorry, please, before, is there any chance of getting Prof. Erik's email address?
It is on the PowerPoint as well. So I can also write it in the chat, but it's also on the PowerPoint, which is okay to share if you want to.
All right. Thank you very much.
Okay. Thank you. So we have one more webinar next week, or on the 18th, rather, on the 18th of this month, same time. So please put it on your calendars, and we'll be going to Germany to look at the case in Germany. So thank you so much for being part of this, and we'll see you again soon. So have a good afternoon, everyone. Bye.
Take care. Thank you, everyone.
Thank you.
Thank you. Bye.
Bye, everyone.
Bye.